Actually, Megan, that's a question for Megan.
I'm ready. I just put the stream link. This is just going to my YouTube stream right now, but if you guys, not right now, but if you guys want to pull it up afterward to be able to view it, feel free to do that.
Okay. You'll let us know how to do that, right?
Yep.
Okay.
So feel free, go for it.
All right, here we go. Good morning, everyone, and welcome. I'm Leanne Taylor with the News on 6 and president of Susan G. Komen, Oklahoma, here in the Tulsa area. As part of October, which is Breast Cancer Awareness Month, we thought it was really important that we gathered together a panel of experts to just share with you the range of questions that people have about breast cancer. You know, most people think that it will never happen to them. You can ask any survivor. That's probably the first thing they'll say is, I thought this happened to older people. I thought it happened to other people. But then when it happens to you, you cannot get the information fast enough. So we wanted to take time out this month to really focus on questions that could be meaningful to you, whether you might be diagnosed, a loved one might be going through this, or just for general breast health information. And so we're going to answer a lot of your questions today about dealing with breast cancer. I want to take a couple of minutes and have our panelists introduce themselves to you and explain why they're part of today's event and why they're so passionate about fighting breast cancer. We'll start with Dr. John Frame. Dr. Frame?
Good morning, everybody. I'm John Frame. I'm a surgeon. I've been in practice in Tulsa, Oklahoma since 1984. Originally trained as a general surgeon, but developed an interest in and a passion for breast disease and specifically breast cancer, so that I've been focusing on breast cancer solely for the last 15 years or so. I've developed a passion for it because I care so much about shepherding women through this journey that they have in going through breast cancer. I'm married. I've been married for 42 years. I have 2 children and 2 grandchildren. And I just love being in Tulsa, Oklahoma, and am so pleased to be with you this morning.
Thank you, Dr. Frame. And Ann Bogie, who's the executive director of Oklahoma Project Woman, and who is also a survivor. Ann.
Thank you, Leanne. I often tell people that I was diagnosed with breast cancer when I was only 29 years old. I didn't have any family history at that time. Unfortunately, my mom was diagnosed 10 months after me. But I also strongly believe that because it was detected early, and because I had great health insurance and didn't have to worry or wonder how I would pay for the different procedures that the doctors recommended, and that I'm sitting here before you today now proudly at 52 years old. So I am also the executive director of Oklahoma Project Woman, like Leanne mentioned. And for those of you who are not familiar with our organization, we provide free breast health care for women and men that have no health insurance and limited financial resources. And then the nice thing is we're able to provide, because of very generous partners, the full continuum of breast care. So from a clinical breast exam, a mammogram, and then even biopsies and surgeries if that's necessary.
Well, I'm very excited that you guys were able to be here today because you have been part of my life as a breast cancer survivor and as a former health reporter and as the current president of Komen, Oklahoma. You know, it was 17 years ago this month that I found the lump myself and began that journey that most women don't think will ever happen to them. You know, as a medical reporter, I had done a years-long study on breast cancer, but even though I felt the lump, I didn't know what to do. I didn't know where to turn. Even though I felt like I was probably one of the more informed people of breast cancer, I still wasn't 100% sure. But I went to my OBGYN and she felt the lump as well and said, you know, I don't think it's anything, but you have to get it checked out. And I think that's today what I want to make sure people know, that, you know, a lump, a bump, a bruise doesn't necessarily mean the worst outcome, but it's definitely a sign that something's going on and you need to go get it checked out. And of course, that process of seeing the doctors and getting another mammogram and the ultrasound and a needle biopsy and all of these words that start coming at you once you hear those words, you have cancer. And I'm glad today that we have Dr. Frame with us because he, as he mentioned, wants to shepherd people through this journey. And I think it's really critical that women and men are armed with the right information that will help them in their battle. Being diagnosed does not mean a death sentence. It's not your grandma's breast cancer, as a lot of patients will tell you. But it does need to be addressed, and it needs to be tackled as quickly as possible and as aggressively as possible. You don't want to let something go too long and put something off that could really be taken care of quickly. Early detection is part of what we want to pass along to you today. And so I want to get to our questions. We've got quite a few questions that have already come to us. And of course, if you have questions, you're welcome to post those as well. Let's just start right off the bat, Dr. Frame. Who is at risk for getting breast cancer?
Well, my glib answer and the truth is that everybody's at risk for breast cancer. Even if you don't have a family history of breast cancer, you are at risk. Simply by virtue of having breasts, you are at risk. 80% of patients newly diagnosed with breast cancer have a negative family history, just like Ann's story. So that doesn't protect you. The flip side of the coin is just because you have a family history of breast cancer, in most cases, certainly does not obligate you to having breast cancer in the future. But everybody is at risk, so every woman and men need to take the appropriate precautions for screening and, as Leanne says, checking things out if something shows up.
Dr. Frame, a lot of people may assume that it is an older woman's disease because many times that's the person that you've met in the past. But we've done stories, and Ann even mentioned, being as young as 29. So age, how does that play a part in this?
Well, certainly the incidence, the frequency of breast cancer increases with age, no doubt about that. So that the peak decade of breast cancer is in the 60s. However, it can be diagnosed as early as age. I have a patient who is diagnosed at age 17. I've taken care of many patients in their 20s, in their 30s, long before the age where we recommend beginning screening mammograms, for example. So lumps and bumps and abnormalities, even in your teens, 20s, 30s, require getting those things checked out.
What does a person do? In my case, finding that lump, that breast self-exam that I did, really because of the story that I had done, checking that every month and then going to my doctor. But if somebody finds those abnormalities or detects something, what's the first step?
Seeing a professional who can decide whether or not additional testing, additional investigation is necessary.
And how did you go about finding your lump? Was it diagnosed through a mammogram?
No, excuse me. I actually found it myself and assumed that it was maybe a lymph node, or I'm not sure that I even really thought. So I went immediately to my physician, and I'm so thankful because he immediately said, "I don't think it's anything, but we need to get it checked." And went from there, and then that was back really before they did biopsies, and I had a lumpectomy, and then had to go back in and get the lymph nodes. But like Dr. Frame said, I think it's so important for women to, anything they notice, to get it taken care of, have it looked at, and that's the goal of our organization, is to never let lack of health insurance or money stand in the way. And we want to get you in front of a doctor, a professional, and let them make the decisions immediately. What is the best course of action at that point?
So Dr. Frame, a lump is kind of the obvious thing that somebody might experience, but share a little bit maybe about what they might see on the breast itself. What are some of the abnormalities that they should be on the lookout for?
Sure, Leanne. Before I answer that question, though, I'm just going to add on to what Ann was talking about, and that is if a woman or man finds a lump that is new, that should be checked out to completion. So we don't watch things. We don't watch things for 6 months. We don't pass them off. If a woman finds a lump, then it's a lump until proven otherwise, which is going to require a good breast exam by a professional and usually an ultrasound. So in addition to lumps that a woman may find, the things that we ask people to be aware of are any change in the contour of the breast, any dimpling of the skin, any out of place, any situation where when looking in the mirror, the nipple and areola look like they're out of place or pointed in the wrong direction. If there's a discharge coming from the nipple, both bloody discharge and non-bloody discharges, lumps in the breast, and then of course any lumps under the armpit as well.
What about bruising or dimpling or skin changes?
So dimpling is a classic sign of a more advanced breast cancer. If there are skin changes such as redness, such as a raised rash, that can be a sign that needs to be checked out. Most of the time that is not going to be cancer, but it needs to be checked out. That is not normal. So any abnormal findings need to be checked out.
So explain to us the process, mammogram, ultrasound, needle biopsy, all of these terms start coming at a patient fast and furious, and you're still trying to process, wait, what's going on? So kind of outline standard care that you would take a patient through.
Sure. So the ultimate goal, Leanne, is when an abnormality is found, one needs to use whatever tools are available to get to the point where you either diagnose the abnormality or say, no, this is okay. So not everybody will need a needle biopsy. Not everybody will need an ultrasound. Not everybody will even need a mammogram. But I think the first step is to have a good exam by someone that knows what they're doing, that can detect whether or not an additional step needs to be made. Some lumps prove to be just lumpy, bumpy breast tissue, but we don't ask the patients to define that. We ask the patients to find it and let us define it. So it starts with an exam, and probably the next step most of the time would be an ultrasound, which is a painless procedure that uses sonar to look at lumps and bumps in the breast tissue. A mammogram is an X-ray of the breast taken in several different views of each breast, but when a lump is present, specific focused X-rays on that lump, when combined with an ultrasound, can determine whether or not a biopsy is necessary. In the olden days, a biopsy meant going to the operating room to have that lump removed. Now, 95% of biopsies are done with a needle under a local anesthetic in the office. About a 5 to 10 minute procedure is all, but that biopsy, which is painless, provides information about that lump, whether or not it's cancer or benign, and it also gives details about how we should approach that with the next step, which is usually surgery. So in summary, an exam plus ultrasound plus mammogram and sometimes a biopsy with a needle in the office.
We'll talk a little bit about mammograms for a little bit, because I know there has been a lot of controversy over when to start having a mammogram. And I believe the American Cancer Society has changed those guidelines. What is your recommendation, Dr. Frame? And then Ann, I'd like you to follow up with that, because what Oklahoma Project Woman does to help those women who can't even afford simple mammograms, which nowadays just seems like should be a common service. Dr. Frame?
So there are two categories of mammograms, Leanne. The first category is screening mammograms, and the second category is diagnostic mammograms. So screening mammograms are done on patients who have no symptoms, no lumps, no discharge, and simply a quick X-ray of the breast to make sure that there's nothing going on in the breast, or to find an abnormality in the breast when it's too small to be felt, to develop a lump. Diagnostic mammograms are what I call focused mammograms, where they're focusing on a problem such as a lump or a discharge or a skin change that's used to further define that abnormality. The controversy about mammograms is in the screening category, because if we screen or do mammograms on every woman out there, we're talking about a significant cost to the healthcare system. So when you balance cost versus how much those mammograms are going to discover, that's where the controversy and the guideline differences come into play. My current recommendation is, unless you have a strong family history of breast cancer, that you have your first mammogram at age 35 and then begin annual mammograms at age 40.
And the thing, just to plug right in there, I did a story back in the day. I was 35, encouraging women to get mammograms, and felt like, well, if I'm telling a viewer about that, I kind of want to know what it would be like. So I did have my first baseline mammogram at the age of 35. And then fast forward 6 years, I found that lump, went in, and I mean, we're talking, it was the size of a pea, 1.1 centimeter. But after having that awareness, that knowledge, I immediately realized that was not a normal feeling. And so being able to go in at 41, that helped. They could look at that previous mammogram and make a determination. And so I thought that was really important, because I think those ages, a lot of people say, I'm past the age of 40 and I've never had a mammogram. And those are the patients that I say, please, when you're done talking to me, call, make that appointment. You need to get in and see someone. And then, Ann, if somebody says, I don't have insurance, I can't afford it, what can they do?
Well, and I think that's the unique thing about Oklahoma Project Womanly, and is that we will really meet the patient where they are. So, for example, if you are 35 years old and your doctor, like Dr. Frame just mentioned, has suggested that you need to have your first mammogram, then we will pay for that. If you were a woman who has always had health insurance and now because of COVID have lost your job and know that you're supposed to have maybe a 6-month follow-up after a previous mammogram, we can start there and we'll pay for that. Or then, unfortunately, still, Leanne, we have many people who call us, have never had a mammogram, but have suddenly found a lump. So our program is based upon what the doctor orders and what the doctor wants. And then we will, kind of help navigate you through that system. And for many, many women, last year we helped about 4,500 women in Oklahoma. And of those ladies, many of them just had a screening mammogram and everything was fine and that's all they needed. About 25% had a diagnostic mammogram where they were actually looking at a lump or a bump that they had found. Some of those moved on to biopsies. Unfortunately, 42 were diagnosed with breast cancer. But regardless of your situation, we will pay for the necessary and appropriate care that your doctor wants you to have.
Yeah, we've talked to your patients before, Ann, in stories, and one in particular I remember from diagnosis through all her treatment, you all were able to manage her care and financially. And Dr. Frame, during all of this, I mean, it is a hardship on families. It's hard on the body. It's hard on the mind. It's hard on the pocketbook. It's hard on relationships. And so to have that one component taken away where financially they're not stressed about that becomes such that lightens a load a little bit.
Yeah. It does. I'm sorry, Ann, go.
No, I'm sorry, Dr. Pham. Leanne, I was just going to say the one thing too that we hear so many times is that, well, a lady knows that she has a lump and says, well, gosh, I don't want to get a mammogram because if it is something, well, then what am I going to do? And we try to emphasize on a daily basis that if, heaven forbid, the mammogram shows that you need to move on to the next steps, then we will pay for that as well. We don't just stop at a mammogram.
Dr. Frame, did you want to add to that?
Just to add that, yes, it is extraordinarily stressful, this process that women are going through. And if they have the financial burden on top of that, it's devastating.
Let's talk a little bit about the diagnosis. So a needle biopsy may have been done, or you have been able to determine that the tissue that there is breast cancer. I know there are different types of breast cancer, and there are different treatments that kind of coincide with those breast cancers. Dr. Frame, would you elaborate on those a little bit for us?
Yes, it gets a little bit confusing, Leanne, and so much can be told by that needle biopsy that's done in the office. So when you don't have to go to the operating room to do a biopsy, and you gather all of this information from a needle biopsy, then you can do appropriate planning for hopefully just one trip to the operating room and get everything done. So I tell patients when they have been when patient has been diagnosed with breast cancer, when I see them, we have all of that information usually in front of us from the needle biopsy. There are different types of breast cancer and different grades or severity or aggressiveness of breast cancer that require different approaches depending on what that biopsy shows. So what is appropriate for this woman is not appropriate for this woman, and so on and so forth. So I tell patients that we basically have 4 tools that we use in treating breast cancer. Tool number 1 is surgery. Tool number 2 is radiation. Tool number 3 is hormone blocking medicine. And tool number 4 is chemotherapy. Now, chemotherapy is the word that most patients dread. And I will tell you that these days, less than 50% of patients with breast cancer require chemotherapy. And certainly less today than, say, 10 years ago. On the other hand, there are certain types of breast cancer that, when discovered, not only require chemotherapy, but require chemotherapy up front to use that as the most aggressive, the most urgent tool to treat that breast cancer.
It's interesting. 17 years ago when I was diagnosed, the surgery was first, and then chemotherapy, and then radiation. And of course, you mentioned it. I think the word chemotherapy just instills fear in a majority of patients, because it's this toxic chemical that is racing through your body, tracking down potential errant cancer cells and killing them. And in the process, you lose your hair. In some patients, you get nauseous, and sometimes you get, your skin color changes. There's all sorts of side effects that people talk about. But I also remembered that the first time when my hair started to fall out, that was a physical sign that the chemo was working. And, there's a lot of empowerment for that. And I know that, I've talked to a lot of patients, and I know both you, Ann, and Dr. Frame have counseled and visited with patients. And that's the one thing is, when you start to lose your hair, though, it's the first outward sign that you're sick. And you can hide the surgery scars and the radiation and all that, but the chemo then is that sign that says something's wrong. And so, for me, it was empowering to have my head shaved by my husband to make sure that I was in charge of when it was all going to fall out. And then, as many of you guys know, I use wigs to get through. My name is Leanne, and my husband's name is Andy. And so I had to have my I had to have my Raggedy Ann, Leanne, and Andy wig. Or there were times when I was going through chemo that my kids said I was kind of a witch. And so, we've got a little bit of Cruella de Vil going on there. But those are those moments that, for me, I had to find ways to embrace this treatment, to know that this is giving me the best chance of long-term survivability. The doctors told me, and Dr. Frame, I would suspect now the type of my cancer, the grade of my cancer, all of those things would probably be treated very differently today. But back then it was after surgery, it was 4 rounds of chemotherapy and the tough stuff, the adriamycin and Cytoxan, and then 33 days of radiation. But knowing that, that when I look back, and to this day, I tell patients this because they're like, man, I really don't want to do chemo. And I said, does your doctor recommend it? And they said, yeah, they really do. And I said, I think that the best option is to do everything in your power so that you'll never look back and ban, I wish I had done this. And that for me has, even the follow-up with hormone replacement there, or the hormone blocking therapy, as Dr. Frame mentioned, there are side effects to all of this, but you have to weigh life and death. And it's like these side effects are temporal, and then they'll move on and we'll be able to have a full life. And so you guys know I got to be on the cover of Tulsa People magazine with no hair. Hello. I always want to be a magazine cover star, but I had to wait till I lost all my hair. But what this did for me was empowered me to tell my story to other women. And Ann, I know when we talk, and you as a survivor, there are women that still keep this as a trouble about it, and they don't want other people to know.
Right. And I think there are, I talk to a lot of women, in particular, Leanne, who they're almost, they go through the appropriate treatments or the treatments that their doctor recommended was appropriate for them. But then they start to compare themselves to other people. Well, gosh, my doctor didn't tell me to do this, and I always, obviously emphasize I'm not a doctor, but just in my, years of experience, just talking to people, all breast cancers are so different, and doctors are going to order the type of treatment that's necessary for you. But I also feel like, and Leanne, I'm sure you were the same way. I know that for years I was scared. I was scared it was going to come back. I was scared about all sorts of things. And I think sometimes, there are different support groups and people out there that you can talk to realize that you don't want fear to take over the life that you're so desperately trying to save and live. But I sometimes think you really have to kind of take a hard stand emotionally to kind of put that fear aside, because it is scary. As you know, my mom did not survive her breast cancer, and that survivor's guilt, if you will. And I'm sure, Leanne, too, that you were like me in that, you surround yourself with a group of people when you're diagnosed who have had it and this and that. And there will be different outcomes for different people. And it's trying to navigate through that and be as supportive as you can be, and realize that there is a lot of support out there for you if you will reach out and talk to some people.
And we'll share more about that a little bit later. Dr. Frame, when we talk about these procedures, go ahead. I want you to also elaborate on, it's not automatically chemo, it's not automatically radiation. And then the doctors that patients are going to meet in their journey. I'm a big believer. I want people to go and see a breast surgeon who does just operate on the breast, that understands how this process works. But you also are going to deal with an oncologist, a radiologist. So kind of elaborate on the types of therapy and which doctors will be coming into their lives.
Breast surgery used to be under the purview of general surgeons until breast surgery became a specialty by itself. And so in most communities, especially the urban communities, breast cancer is dealt with by breast surgeons like myself. It's ideal, I think, somewhat biasedly so, but I think it's ideal for a woman or a man with breast cancer or a breast problem to see a breast surgeon to solve that problem and to get them started on their journey. In addition to a breast surgeon, when dealing with breast cancer, however, you're going to most of the time, not all of the time, but most of the time, see a medical oncologist. And a medical oncologist is a cancer specialist who deals in medicines like chemotherapy and the hormone blocking medicine that we talked about. You also may meet a radiation oncologist if you need radiation. So a radiation oncologist is a cancer specialist who deals with radiation. I'm going to go back, though, Leanne, to a previous conversation between you and Ann about support around newly diagnosed breast cancer patients. And I'm going to give an admonition to everyone that I give to all of my patients. First of all, there is a lot of good information out on the internet, but please don't go camp on the internet. It will scare you to death. You need someone to guide you through the scary words of breast cancer. And Dr. Google, if I may, is not able to discern what type of cancer you have without the reports in front of Dr. Google. And your treatment may vary tremendously from what you're reading on the internet. That said, there are very good sites out there on the internet, but let your doctor direct you to those sites, not doing a search about breast cancer. Secondly, when you're diagnosed with breast cancer, as I'm sure you, Ann, and Leanne discovered, you are amazed at how many colleagues, acquaintances, neighbors, relatives you have that have had a brush with breast cancer, either a Sunday school classmate or a neighbor or a relative or what have you. And every one of those people means so very well, but they all have advice for you. Just like you said, well, that's not what my doctor told me. You ought to try this. This is what you should do. Without knowing the details of your specific diagnosis, no one can give you advice on what you should do. So be careful about that.
Good suggestions there. Very well done. So someone's been diagnosed. The plan of attack is in place. They're going through the procedures. Once they're wrapped up, you have that feeling is like, am I cured? And Dr. Frame, that's just not the word we can use, is it?
It's not, but that's the question that everybody asks, of course. And I'm sympathetic to that. So we talk somewhere along the journey about the statistics, about the prognosis. How likely am I to be cured? How likely is this cancer to come back? And we always put a realistic spin on it, but we want everybody to be on the positive side of those statistics. So a positive attitude is very important. Breast cancer treatment includes surveillance in the future for those next 5 to 10 years when breast cancer would be most likely to recur, to come back someplace. And through a combination of conversation with the patient, physical examination of the patient, and scans where appropriate, is how we watch over patients in the surveillance time after she has completed treatment for breast cancer.
Would you recommend for patients, let's talk two things, about genetic testing and about clinical trials? I know that you mentioned 85% of women who are diagnosed have no genetic component. And when I was diagnosed, my mom and my dad both adopted. So I don't know my genetic history. So there was that pull to know. Then there was the pull not to know, because I have a daughter and insurance and pre-existing conditions. You get to start asking yourself, if I know I carry the gene and my daughter could develop it, how is that going to help or hurt her in the future? So it took me almost 10 years before I actually had the genetic testing done. And clinical trials, I was never exposed to that, but I've heard of people, the drug tamoxifen. I remember years and years ago doing a story at St. Francis when they were doing, it was in trial stages. And now that's a drug that I took for 10 years post-cancer.
So two very broad topics.
And you're welcome.
So just a correction. I said 85% of women diagnosed with breast cancer have a negative family history. In fact, of all breast cancers out there, only about 4% will prove to have a genetic driver of the disease. So who should be tested who should have genetic testing? So when we do genetic testing these days, we're actually testing for a whole variety of gene mutations that may predispose a woman to breast cancer. The original two genes that we knew about were BRCA1 and 2. But in the last 10 years, researchers have discovered more and more genes that have something to do with the predisposition to developing breast cancer. So we test for all of those genes. Who should be tested? So anybody who's been diagnosed with breast cancer should be tested, or we would recommend that they be tested. There are pros and cons to being tested, and I'll get to that in a second. Anybody with a strong family history of breast cancer should be tested. Now, that conversation about whether to or not to test should happen between the patient and either the breast surgeon or the medical oncologist or a genetics counselor. And then an individual decision can be made about whether to go forward with that testing. The testing is simple. It's not even a blood test anymore. It's a saliva test. So if you're a good spitter, you can do the test. The test is about a 2-week turnaround, and it will tell you whether or not you harbor any of those genes. Now, I tell all of my patients, even those that have been diagnosed with breast cancer or those that have a strong family history of breast cancer, they're likely to be negative because, as I said, only 4% of breast cancers actually carry those genes. But if you are found to have one of those genes, it creates a whole different conversation with your breast surgeon and oncologist about what is the appropriate treatment. Secondly, any one of that person's first-degree relatives should also be tested. So I'm talking mom, dad, brothers, sisters, sons, and daughters. That gene can be carried through the boys as well as the girls. So lots of people would then need to be tested, and it's a potentially life-saving test because of that gene's predisposition to developing breast cancer. Your second question was about clinical trials. Clinical trials these days have to do mostly with chemotherapy, researchers trying to come up with a better combination of chemotherapies to give a better result, that is, a better cure rate. In a clinical trial, you're never going to be asked to potentially take a combination that is worse than the known combination of drugs and the benefit it provides. So, for the sake of those people that come after you, I would encourage everyone to strongly consider participating in a clinical trial, which should be very carefully outlined by your medical oncologist.
And you want to talk a little bit about the genetic testing that you went through and then your mom being diagnosed after that?
Sure, absolutely. And Leanne, I kind of did it probably a little bit backwards in that I did not want to have the genetic test when I was first, actually after my mom was diagnosed, because I assumed that we would have the gene. And I did not ever want my mom to feel like that she had given me breast cancer. So I did not have the genetic test until after she passed away. But I had it because I have 2 sisters and, 10 nieces and nephews. And honestly, when it came back that we did not have the gene, I was almost more angry because then it really didn't make sense. And that sounds so funny, but, I think sometimes we forget how much emotion is wrapped up in a lot of the different decisions that we make or don't make. And I'm very glad I had it. My sisters have since had it. But I sometimes see with people that for some, knowledge is power and they really want to know, and others are scared to death to find out. And, in my role, I try to be respectful of both cases. So,
and share with us a little bit about Oklahoma Project Woman, and because this has really expanded statewide, people all across Oklahoma, all 77 counties can benefit from what you all provide. How are you funded, and what have you seen in the years that you guys have been in service?
Well, we started in 1998, and since that time have provided what we say free care, access to care for more than 61,000 Oklahomans. 827 as of yesterday had been diagnosed with breast cancer. We are very fortunate in that we partner with about 60 hospitals across the state, and as well as the radiologists and the surgeons and pathologists, really anyone who's needed to take care of those patients to make sure that they receive all those small compensation for taking care of the ladies. And they are very, very generous. We receive funding from foundations, from Komen, and individuals, corporations. Our biggest issue, of course, just like every other nonprofit, is that now is a really tough time. We've had to cancel all of our events, that we are very dependent on that event income. We do not receive any type of government funding. And so it's important for us to get those corporations and individuals involved in these events. I will say that I think most people understand that events have been canceled. And so we are starting to see the donations come in anyway. But then the double-edged sword is that there are so many more people who need our help because of COVID, because they've lost their job. They can't afford to do COBRA. So it's a very tough time, but we will continue to help as many women as we have the funds to help.
Let's talk a little bit about helping these women emotionally. I know that, for me, and everybody's different, as Dr. Frame mentioned. I mean, some people want to surround themselves with big groups of people and to get all their emotions out, and some people want to walk the journey all by themselves. What do you see the patients that come in and the caregivers? I mean, that is such a big component to all of this. If they've got a support system already in place, if they have a spouse, if they have siblings or parents that can come along, because quite frankly, you can become sick. Some people have to stay home and go through treatment and not work. And so it does become a big challenge.
Right. And I think that is perhaps one of the biggest issues for the ladies that we help, is that they might already be at a difficult spot in life. They don't have health insurance. They're doing everything they can to work 40 hours a week just to put food on the table. You have a lot of single moms. And so, by nature of their situation, they don't have that support group. And they are scared to death that if they have to have chemo and they get very, very sick, then they won't be able to continue working and provide for their family. So again, we really try to emphasize that every breast cancer is different. Every treatment plan is different. What works for you might not work for the other person, and really just try to take it in steps, baby steps, and get them through that process, because it is very scary. You know, there are luckily other programs out there that provide financial support for things like rent and food and utilities. And there are support groups out there that can help them navigate. But, you know, our most important goal is that they know they will receive all of the breast health care that they absolutely need at no expense, which I think people, to this day, people say, really? I don't have to pay for anything? No, you really don't. And that's, you know, the amount we reimburse our coalition partners is payment in full. So they will not, you know, the patient will not be billed anything else. So
just a dovetail off of that, because I do want to mention a few organizations right now. We have about 10 minutes left, and I've got several questions that are real specific that I want to get to. But a couple of things. For newly young diagnosed patients, there's a new organization, relatively new organization called Project 31. A woman created this because she was a young survivor, and because there are so many issues that young patients might have to deal with that older women don't. You know, Dr. Frame, if a patient goes on chemotherapy, sometimes that can push them into to menopause. And so there's the whole issue, and correct me if I'm wrong there, because I want to make sure I don't want to give the wrong information, but the discussion on, if I haven't had children yet, this chemotherapy, how is that going to impact my fertility?
It's an important discussion, Leanne, and thanks for bringing that up. So a woman who is still of childbearing age, the conversation needs to happen prior to starting chemotherapy about her desire for additional children. And if that desire is there and she is destined to have chemotherapy, then she can potentially harvest and donate and store eggs for the future or in vitro fertilization for after chemotherapy is complete.
So this Project 31 is for young women to have these open conversations to support each other. So that is one, unfortunately, because of COVID, they're only able to meet virtually, but normally they meet in hospitals across the state. So that is one organization that I would recommend. Joy in the Cause is another local organization. And I know a lot of patients that get diagnosed, as you mentioned, they might need a gas card, or they may need help with their utility bill. And unfortunately, some organizations aren't able to give out the financial support, but Joy in the Cause can come along and help with a gas card or two, and they help take care of the whole family. And so that's another organization that I'm a big supporter of, and I've seen what they've done. And again, all of these nonprofits need our support because they are needed so hard. Right now, it's such a hard time because you're having more patients. The services have to be there. And so I just highly recommend, if people have nonprofits that they've followed, that they've supported in the past, you know that they've been vetted and where their dollars go. I recommend if you are blessed and able, now is a perfect time to bless these local nonprofits so that they continue with the organizations and getting those services out. So let me go through a couple of these questions. And it says, I want to support my friend who's fighting breast cancer, but I'm not sure where to start. What things could I do for her? And Ann, I know you and I both, as survivors, understand what it means when a friend or a colleague comes alongside and says, hey, let me help you. What helped you?
I think what helped me and what I have seen helped. Well, I've had, unfortunately, several friends recently diagnosed, is being a good listener and not trying to share your own story. Because I know for me, and I have people ask, well, how sick were you during chemo? Well, but that was so long ago. It's so different. And so I tried to be a very good listener. And the one thing that I personally have found helpful is I have volunteered a couple of times to go along with their surgeon when they meet with their surgeon, if their surgeon will allow it. And now this was obviously pre-COVID, but and take notes. just take notes and let them talk to, and ask all of the questions of a Dr. Frame, and then just someone to sit there and not utter a peep, but to take all of the notes, because there are so many things, as we found in this last hour, that you want to know about. But I think those are the kind of things, just to be that sounding board. And then there's certain meals and kiddos and all of that. I was very lucky when I was diagnosed. I was just newly married and did not have any children yet. And, now here we are and I have 4. So, but I that would probably be my best advice. Just listen and be a good sounding board for them.
Yeah, and I think as a patient, it's really important to let others do for you. I think that there are personalities. I can't name names, but you want to do this on your own, and you're like, I can do this. I want to be Superwoman, and I don't need anybody. And then, it's that person who says, let me bring you dinner. Let me pick up the kids. Let me do the dry cleaning. Let me help you, because they want that blessing too. They want to be a part of your journey, but they can't be there for the treatment. They can't be there for the radiation and the surgeries. It's just being available, and as you said, listening. I think that's critical. Another question, Dr. Frame, I know a lot of times breast cancer diagnosis for a woman can be damaging to a marriage. I've heard of some patients whose husbands just can't cope. What can husbands and those support partners do to really be there for their loved one?
My advice comes from observation of the last 35 years. I've seen couples fall apart. I've seen husbands leave. Be an active part of the process. Be there for the appointments. Be there as a listener, as Ann pointed out. When you first are dealing with this diagnosis, and all of these terms are coming at you, when you meet with a surgeon, when I meet with my newly diagnosed patients, they hear about 5% of what I say. 5%. So that second set of ears is extremely important to get a more complete understanding and takeaway of the conversation. And then if your surgeon can provide notes for you of the conversation like we try to do, then I think there's a better understanding for that couple at home to go back over that conversation and make sure they fill in the missing gaps. So if the husband can be there, present for the appointments, that is extremely helpful. And then, as Ann said, be a good listener. We all have different levels of ability to be empathetic and sympathetic. So put on your sympathetic hat and be sympathetic.
This is a great question, Dr. Frame, and I meant to bring it up earlier. The conversation about dense breast tissue. This viewer says, I've had 3 mammograms and they all say that I have dense tissue. They cannot fully see if there is or is not any spots to be concerned with. How do you manage something like that? Should there be additional testing? So
mammograms are not perfect. Please don't take that as a reason to not have a mammogram. But a mammogram is not perfect. And it becomes less perfect when a mammogram is trying to see through dense breast tissue. If you have dense breast tissue, it's not anything you're doing, it's what God gave you. Breast tissue tends to get less dense as you get older, so younger women have more dense breast tissue. But if you have a certain level of breast density, then that mammogram becomes less reliable standing by itself. So many times, if you have dense breast tissue, we will have to add something on top of a mammogram, not in place of, but on top of a mammogram, which would include either an MRI or what I prefer is a whole breast ultrasound. So yes, it's important to know that if you have dense breast tissue, you may need something else besides a mammogram.
I also want you to hit on prevention. Some women have been told, if I breastfeed my child, that reduces my risk of breast cancer, or conversations about diet soda. I've heard the wives' tale about deodorant, can cause breast cancer. What are your takeaways about, as we kind of wrap this up, as women go forward? Obviously, early detection's the key, getting your mammogram, doing breast self-exam. But what about these other kinds of preventions?
By and large, with the exception of an inherited breast cancer, by and large, we do not know what causes breast cancer. There's something out there. Somebody someday will be able to discover it. But right now, we do not know what causes breast cancer. Consequently, I can't tell a woman what to avoid or what to take to prevent breast cancer because we don't know the cause. It's not deodorant. It's not soy. It's not tobacco. It's not alcohol. It's not taking estrogens. All of those things have been written about, and you can find data out there on Google to support whatever you want to believe about any of those things I mentioned. But the bottom line is, by avoiding any of those things that we mentioned is not going to guarantee that you don't have breast cancer, nor is it going to significantly reduce your chance of getting breast cancer. If you have an inherited gene, that's important for breast cancer. If you've had a biopsy that shows some precancerous changes, then you can help to reduce your chance of developing breast cancer by taking that medicine called tamoxifen, the hormone blocking medicine that we mentioned earlier.
Awesome. Anne, would you like to have some closing thoughts as we wrap up now?
You know what? Can I ask a question, Leanne? What do you and Dr. Frame think about touching on the women living with metastatic breast cancer? I feel like for the first time, that number just continues to grow. We have as Leanne, you obviously know this because you have spoken at it several times, but we have our big fundraising event down in McAllister. And because it's a small town, we have all of the survivors come up to the stage and they get a rose and they tell the number of years that they've, been a survivor. Well, last October, so a year ago, for the first time we had, and again, this is in McAllister, Oklahoma, 6 or 7 women come forward to say that they were living with metastatic breast cancer. And, for me, obviously, when I was diagnosed back in the dark ages, when it metastasized, that was a death sentence. And I don't know. I'm not sure. I personally have a very good friend living with it right now. And, her cancer came back in her bones, I think 6 or 7 years ago. And she's still living this wonderful, not treatment free by any means, but living a good life. And it just seems like we've made a lot of progress. But I'm not sure the appropriate way to address it.
I think when we discuss the types of breast cancer, I think we can easily segue into that. And I think it's a very valid question and point, especially because there's a lot of advertisements right now for patients who are living with metastatic breast cancer. It's a big push for Komen. So Dr. Frame, I might suggest we include that when we talk about the types, if you think that would be a good place for it.
Yes. And I think, my statement is going to be, yes, breast cancer can kill. It can. But even with stage 4 breast cancer, it's not a reason to lose hope because of the improvements in treatment for metastatic breast cancer, so that people are living years and years and years with metastatic breast cancer. In some cases, not all, but in some cases.
I love that. And Anne, I would love you to follow up after he mentions it with the story about your friend who is living with it. I love it when we can bring that personal example or story of someone and the joy that they can still have in their lives and the things that they still get to do, and what that looks like and how it is so different. I think that's a great way to put a face with the story of living with the metastatic breast cancer. sorry to interrupt. I just wanted to chime in with how that might flow and how we could add that personal story, because I think that that's great.
Okay. No, that's great. And, I think my overall belief is that, every day, there's so much money that goes into research, and I really do believe that it's paying off. And I think, the treatment of metastatic breast cancer is probably a great example.
Leanne, oh, sorry, go ahead.
No, I was just going to say, we've had just 2 of the stories that I did this year leading up to the race were both 2 metastatic patients. And so it's the fact that you hear it's not curable, but it's treatable, and it's going to be the way their life will be for their lives. And I think again, I want this to be informative. I don't want it, but I think when people hear metastatic, they're like, well, what does that mean? And I'll have Dr. Frame kind of elaborate more on that. How it's the original cancer, but it's now spread to the brain, the lung, the bones, or whatever. So he can give us a little bit more clinical side of that.
Leanne, in closing, would you and Anne want to speak to what life is like after breast cancer? And I know, is there ever really an after breast cancer? I know we talk about the surveillance and we talk about the recurrence, but to talk about what life is after, is there after? Is that a misnomer? And you mentioned your kids and all the joy that you have after your journey. I think that might be a real positive way and personal way to close it out. What do you think about that, Leanne?
I love it. That's a great segue. At the very end, we can just say, we've given you a lot of information, but the bottom line is Anne and I can be representative of the 3.5 million breast cancer survivors in the country. Our stories aren't unique. We just have these platforms that we get to share our story, and then we can elaborate a little bit more on life after. Because, Anne, I would suspect, when you're going through this, the thought of even having children and having a family, the first thing I thought of was, who's going to raise my kids? And I just heard the words, you have cancer. And that's,
right.
I was already mad at my husband because he had already remarried and somebody else was taking my place. And you're just like, your mind becomes so irrational that you're like, stop, you've just got to get through this. And so, yeah, there is definitely life after, but I'll never forget, towards the end of the treatment and wrapping up and sitting there, and there was a magazine and it says, your risk for recurrence. And it never dawned on me, Dr. Frame, that I would even need to think about it recurring. I thought this is over and done with, but it's never over. You're always aware and cognizant. Every year I do the mammogram, every month I do the breast self-exam. All of those things become so personal that, yes, I live my life after the diagnosis, but you are a survivor indefinitely.
Absolutely. And I think, Leanne, I think you and I might have talked about this before. I always say that if I had to get breast cancer, I'm really glad I got it young, because I think it totally changed my perspective on the world and what really matters. And that sounds silly, but at the same time, when you sort of get a second opportunity at life and what's important and what's not, I feel kind of blessed that I got it at 29. I'm glad I didn't have to. I'm glad I didn't have to wait until I was 65 to figure out that maybe my priorities, weren't what they needed to be. I worked a whole lot. I was back in corporate America, and then not long after my breast cancer, I joined Oklahoma Project Woman, and like I said, now have 4 babies, and feel like I'm part of a good club.
Yeah, sorority we would never have applied for, but glad that we're in it now. Well,
right.
Thank you guys so much. I think that's what we'll do is we'll kind of wrap up with that. Dr. Frame, do you want to hit on anything else before we wrap?
No, I think we covered it nicely. That's good.
Good. Well, I think I'll finish up with, we hope this discussion has certainly given you more insight into breast cancer and help you or someone you love navigate the journey through breast cancer and be on the other side of this diagnosis. Thank you so much for joining us, and so long for now.